Regarding patient number 1, we have a 45-year-old male who's been married for 15 years and has 2 children. The patient has a history of major depressive disorder and a pornography addiction. He's reporting that his addiction has caused marital problems, but for the past 5 years, his marriage has improved, and he currently denies looking at pornography. His symptoms with major depressive disorder began in his 20s, and they've been well managed with Celexa 20 milligrams daily. Today, the patient presents visibly upset and reports that his wife has been having an extramarital affair for the past 2 years. The patient reports coming home from work to find that his wife and children were gone, and he found a note left by his wife that detailed her infidelity and her plans to take their children to live with her and her new partner. The patient reports that divorce proceedings are in effect and expresses deep disappointment and extreme sadness at feeling betrayed in light of his efforts to improve himself. The patient states that his job is in jeopardy in light of his inability to function due to deep depression regarding the loss of his children. When asked about suicidal or homicidal ideations, the patient responds by saying he has been suicidal since his wife and children left, and he reports drinking at least a 6-pack of beer every night. He further reports plans to shoot himself. When asked what is keeping him from acting on a suicidal ideation, the patient responds by saying his kids are the reason he has not acted on his ideation. However, the patient reports that he's losing hope of ever seeing or talking to them again. This patient is at a critical junction. Feelings of hopelessness and betrayal, along with the loss of his family, place him at a high risk for suicide. Therefore, my primary focus would be on his suicidal ideation. Suicidal ideation, if not appropriately addressed, has a potential for grave outcomes. It is concerning that this patient has reported a concrete plan to act on his ideation. I would first ask the patient if he has access to a firearm. Access to a firearm is associated with a dramatically elevated risk of suicide. Men who own handguns are 8 times more likely to die of a gun suicide than men who do not possess a firearm. The patient's answer to this question will determine the severity of his situation. I would inquire about any family history of suicide, and I would conduct a comprehensive psychiatric evaluation that encompasses a range of factors. This would include questions about the current suicidal ideation and any history of previous attempts. This patient's comorbidity of major depressive disorder increases his risk of acting on his suicidal ideation. In addition, his alcohol use significantly heightens his suicide risk, especially when compounded with a history of depression. In light of these aggregating factors, I would discuss and identify protective factors. Protective factors are people or circumstances that motivate patients to continue living. Therefore, I would shift my focus and his focus to his kids. Since he has expressed that they are what stop him from taking his life, focusing on them may provide some hope to deter him from taking his life. The implementation of an evidence-based assessment tool, such as the Columbia Suicide Severity Rating Scale, may yield some valuable information to shed light on the severity of his suicidal ideation. The patient's depression has been well managed by Celexa. However, I might consider an adjunct medication to help reduce his depressive symptoms. I might consider referring the patient for ketamine infusions. Research has shown that repeated doses of ketamine rapidly and robustly decreased suicidal ideation in patients. However, this patient's use of alcohol poses concerns regarding drug interactions with both Celexa and ketamine. Therefore, it would be important to address the patient's substance use disorder, as alcohol, a depressant, may be exacerbating his depressive symptoms. So to conclude, I would strongly consider placing the patient on a 5150 hold for suicidal ideation and danger to self. A safety plan is the primary concern, and placing him on a 5150 hold for his safety and rehabilitation would serve as a protective factor. Consequently, I would refer him for psychotherapy and/or cognitive behavioral therapy to provide an avenue for the patient to confront his circumstances from a sober and healthy perspective. Cognitive behavioral therapy for suicidal ideation is pragmatic, problem and solution oriented, empirically tested, and compatible with pharmacotherapy and other approaches.